have to give Tegretol. And you'll use other medications of that nature. So you have paroxysmal neuralgias, you have continuous neuralgias, you have deafferentation pain, which is like phantom limb pain, you have neuromas, reflex sympathetic dystrophy, and atypical odontalgia. Now, under the psychogenic pain category, you have major depression, somatization, conversion disorder, and hypochondriasis. And you have to ask yourself the question, what came first, the chicken or the egg? Normally, you're seeing these patients many years after the pain first started. They've been to every type of physician, chiropractor, osteopath, you name it. Nobody has diagnosed what's wrong with them. They get depressed, they're frustrated, and I think a lot of the psychological symptoms that they present, they're there now, but I have to question, and I have the literature to support what I'm saying, whether it is strictly psychogenic in nature, as many people would lead you to believe, or that they say it's bruxing and clenching, or today they even say that occlusion has nothing whatsoever to do with this. I think occlusion is a poor term. If you're talking about orthopedic relationships of jaws, I could accept that a lot better. But there is, those of us that are clinically involved feel that there still is a correlation. Nobody has disproven it scientifically. They just allude to it. Of course, it suits the purpose of people who only treat, there are certain people in our field that treat this and this primarily. And most of their referrals are coming from neurologists. So when somebody gets up on a platform and lectures to a group such as yours, you've got to understand where they're coming from and what their backgrounds are. It's time to get out of the dark. It was Abraham Lincoln that said, you can't escape the responsibility of tomorrow by evading it today. And the same thing holds true for mercury. It's the same. Our problem is no different than yours. And you have to fight just as hard to do what you think is right today in this area as you have to do in the area in which you're in. I was out on the West Coast, probably, I think, because I met some of the fellows here that I've lectured to in different parts of the country, and I think I was up, in the state of Washington, and I picked up the newspaper, and I saw these two ads in the same paper. And it says, a dentist shouldn't simply be used as a repairman. And it shows you what's on a bracket table. And this was the Travelers Goes National with a dental plan that encourages checkups as an automatic part of every policy. Well, Travelers was trying to get employers to buy policies for employees so they covered them dentally. But more important was this one by Metropolitan Life. Over 1 million American workers will call in sick today. Chronic pain. Some of it's acute, but it develops into chronic pain. And most large corporations want the people that are working for them to be at work every day. And you can play a tremendous role in getting those people back to work. You don't even know it because nobody ever explained it to you. Let me give you a for instance. I have a pain center named after me at Tufts, which we initiated it in 1985. Last year it was 9 years old. Tufts University was 125 years old last year, same year. The most successful clinic in the school financially is the Gelb Pain Center. In 9 years. Doesn't it tell you something? You don't have to be a genius to figure it out. And the emphasis is not primarily here, but is here. You're treating, it's the difference between being an excellent technician. So when I say to people, who is the most respected member of the sophomore class? The best basic scientist. The most respected member of the senior class, the best technician. That's what's wrong with dentistry. And it's the unusual dentist that 5 or 10 years out of school puts together the first 2 years with the last 2 years and understands why they were put there. We want oral physicians, dental physicians. That's what we're looking for. One of the best books out, I think, on the subject is this book on myofascial pain, the Trigger Point Manual, by Janet Travell and David Simons. And chapter 4 are perpetuating factors. So let's say some of the other things that contribute to make people come up with situations such as you and I would see. Mechanical stresses, one leg just being shorter than the other. Skeletal disproportions or a long second metatarsal bone, the W.J. Morton foot. Other sources of muscular stress such as misfitting furniture, poor posture, abuse of muscles, constricting pressure on muscles, and prolonged immobility are frequently significant. Nutritional inadequacies. You're into this. Look at all the people here that are presenting, your exhibitors. Low normal levels of vitamin B1, B6, B12, and or folic acid are suboptimal, frequently are responsible when only transitory relief is obtained by specific myofascial treatment of involved muscles. Vitamin C deficiency causes post-exercise stiffness and increases bleeding at sites of injection. Low levels of this vitamin are the rule in smokers. Vitamin inadequacies are confirmed by measuring blood serum levels, symptoms used to respond to oral supplements. So of course nutrition has to be a major part of what we're doing. Metabolic and endocrine inadequacies. 80% of the patients are female. The two things that I look for most are hormonal imbalances, primarily thyroid and estrogen. The patient's past the menopause, has had an early hysterectomy, partial or full, I'm very concerned. I ask every female 6 questions. Do your nails break easily? Is your skin dry? Do you tire easily? Does cold weather bother you? Do you have cold hands and cold feet? And do you have trouble controlling your weight? If the answers to most of those are yes, I'm going to get a thyroid hormonal examination by an endocrinologist. So these are things that I think are important that you have to keep in mind. Psychological factors, of course. But I think in our field, this has been overdone. That inhibit rapid recovery include depression, tension caused by anxiety, the good sport syndrome, secondary gain, and sick behavior. Chronic infections will prevent these people from getting well. So I would imagine that if the person had even something such as toxicity to silver amalgam, that can impede the progress of them getting better. Due to either viral or bacterial disease and some parasitic infestation can prevent recovery from myofascial pain. Other factors such as allergy, impaired sleep, radiculopathy, and chronic visceral disease prolong the treatment. So various tests can be done to verify this. Okay. A very interesting study was done by Eugene Williamson, who used to be at the University of Georgia, Dental School of the Department of Orthodontics. He studied the height of the ramus and the length of the body of the mandible, and on average, one side was lower than the other. The ramus, 2.8 millimeters with a range of 0 to 8, and the corpus, the body was off 2.67 millimeters with a range of 0 to 11 millimeters. Bezer in the Netherlands did a condyle symmetry exam, myogenous 910, arthrogenous 4.83 differences. Habits condyle symmetry more common in craniomandibular patients than the controls. Now, on every side that the patient had a shorter ramus, on every side that the patient had a shorter mandible, length of the mandible, there was always a class 2 tooth side. That was always the class 2 tooth side. And the class 2 tooth side tends to be the short side. A study was done at Tufts by George White and Maria Lagaida on 20 children. 20 of 20 chewed on the short, low class 2 side, and it was 13 right and 7 left. This was also the most collapsed side. It was also the high eye side, and condylar flattening is seen on the opposite side. In most patients, the low side is the right. The side that develops degenerative changes is the left, the good side, the compensatory side, the overworked side. Muscularly, there are more symptoms on the left as a rule than on the right because it's the good side and the right side's the off side. So the high side, facially, tends to be the off side. You're working in patients' mouths every day, you don't see this. Look into the mouth and look at the planes of occlusion. In almost every single mouth that I look, the plane of occlusion in the lower left posterior quadrant is higher than the plane of occlusion in the lower right posterior quadrant. And I think it starts the day they're born. This is a little bit Can you just move that over? There's a difference between the acute pain patient and the chronic pain patient. And the characteristics are very important. And this changed probably at the end of about 6 months. So I don't think I can see it any better. Usually what it says is the onset is sudden, and you can really pinpoint the area. There's a correlation between where the patient is complaining of the problem and what you find biologically. It serves a useful purpose. In the chronic pain patient, it doesn't. Now, in the chronic pain patient, there are some other characteristics that you see, such as usually extreme abuse of medications. Multiple surgical procedures may have been performed. The extent of the pain seems much greater than the organic pathology. The patients may become depressed, hypochondriacal, and hysterical. Pain games may predominate in the patient's behavior patterns, and symptoms and complaints can be compounded or prolonged in the presence of ongoing litigation. So these are things that you have to be aware of that make the chronic pain patient much different than the acute pain patient. You are trained specifically in a dental education to take care of acute pain. There is nothing in your education that prepares you to treat a chronic pain patient. Although we now have, from the American Society for the Study of Pain and the American Pain Society, we have curriculum guidelines for a program that should be instituted at the university level. As a matter of fact, I was surprised in talking to somebody, I won't mention the name, I just was on a cruise with my family, and they happened to be from Toronto. And Barry Cecil, who's the new dean of the school, is probably one of the top pain investigators, not only in Canada, but in the North American continent. And I was surprised they didn't have a temporomandibular clinic at Toronto. Do they have one in Calgary? Why not?
They have one in Edmonton.
Oh, that's very nice. Edmonton, it's a little far away. I'd rather travel. If I'm in Calgary, I want to be treated in Calgary. So one of my purposes when I go around to lecture and lecture people, I would like to educate as many of the dentists as I can so patients don't have to move or take long trips to be treated. And you'll see patients, if you're on the top of Mount Everest or in the middle of the Mojave Desert, they'll find you. They have to. They have no choice. And they're out there in the multi-millions. Multi-millions. Okay, how do I arrive at a diagnosis? I do 7 things primarily. I take a very complete history in which I acknowledge all the medical, dental, and TMJ aspects of the problem. I then visualize. I look at the face, the level of the eyes, the lips, everything else. I look at the level of the shoulders, hips, breasts, and knees. I palpate all the muscles, major muscles of mastication. I palpate the condyles through the external auditory meatai. I take x-rays of the joint, and people say, I talk about a 4-7 position. Okay? Let me give you a definition, if I can, of centric that has come from the Journal of Prosthodontics, Glossary of Prosthodontic Terms, and then I'm going to ask you, how do you find that position? Okay? This is the present definition. Now, you have to understand that as an undergraduate teacher in technique, if I have to teach a student how to mount a case on an articulator, I use a reproducible position, which is terminal hinge. It may not be biologic, but I can at least teach them how to mount the case over and over again to the same position. This is the present definition of centric relation. A maxillomandibular relationship in which the condyles articulate with the thinnest avascular portion of their respective discs with a complex in the anterior superior position against the slopes of the articular eminences. This position is independent of tooth contact. This position is clinically discernible when the mandible is directed anteriorly and superiorly and restricted to a purely rotary movement about a transverse horizontal axis. Centric occlusion, therefore, is the occlusion of opposing teeth when the mandible is in centric relation. This may or may not coincide with the maximum intercostal position, and rarely does. It may occur in 5% of the cases. So if I said to you today, tell me, how do you find this position? When everything is in its proper anatomical relationship, and maybe on some of the other slides you'll see it, the condyle, I find, is downward and forward against the posterior slope of the eminence. The greatest amount of space is superior and posterior. That's an ideal position. At least that's nature's position. And in an endeavor to interpret it for you, we have called this the 4-7 position. So if you drew a plumb line, put a line tangential to the top of the fossa and one to the eminence, measure the distance between the two, divide the fossa in half, and when the anterior part hit the eminence, drop a plumb line straight down at right angles, and then divide the fossa in half vertically. You can divide the fossa into 8 boxes. In its proper relationship, the bulk of the head of the condyle will be in the 4-7 position, almost every single time. And you know what's interesting? Nature does it for you. What do I mean? If you take a picture of a patient on a transcranial or a tomo, and you take them closed in habitual occlusion, take them at rest, and take them wide open, the patient's condyle will go from the habitual position, which may be superior or posteriorly displaced, and come down to almost that 4-7 position every single time. So I kid around with the dentist. I said, you know, about 10 million years ago, nature said one day there's going to be a profession called dentist. And I think they're going to be nice people. And they're going to get interested in a subject called temporomandibular disorders. And they're also going to develop instruments to take pictures of these joints. I want to help them. So when they take a patient from closed to rest to open, the rest position is going to be very close to where the corrected centric should be. Ha, ha, ha. And it happens over and over and over again. So sometimes we're not all crazy. Okay, so we do a 3-dimensional analysis, and this is from Purcell's book on physiology of occlusion and rehabilitation. He talked about a sagittal plane, a horizontal plane, and a frontal or coronal plane. So we try to transpose this onto our models. And we mount them, and we get a wax bag. So what are we trying to do? In essence, our treatment goals are to educate and assure the patient, which you must do with informed consent, and not like some of the other people we know. We have to reduce the hyperactivity of muscles. We have to stabilize the position of the condyles. We have to reduce parafunctional activity and stabilize the occlusion as necessary. The idea is to do the least and not the most, and if possible, wean as many people off the appliances as you can. And maybe just have them wear them at night if they're clenches or bruxes or what have you. A certain percentage may have to have ortho, and a certain percentage may need to have restorative. The treatment regimen that most of us follow are these. We take baseline records, and you must arrive at a diagnosis first. Without a diagnosis, you can't treat. Then we will use repair and regeneration of the injured tissue, as well as behavior modification to get them well. And lastly, we'll do orthopedic stabilization by whatever means we need. Sometimes it may just be a minor causal equilibration after this is done. It may be ortho, it may be prosthetics, it may be nothing, and it may even have to be resolved by a surgical procedure. But surgery has to be the absolute last resort. The worst thing you could do is to send some of these patients to a surgeon first. They're taught how to cut. And we reduce in our office most closed locks non-surgically. I mean in the high 90%. And if I do it, you can do it. But if I'm a surgeon and I get that patient first and I take an MRI and a CAT scan, I have every right with a displaced disc without reduction to surgerize the patient. And the insurance companies will pay for the surgery faster than they will for conservative therapy. And there are 2 states in this country that have passed laws due to the power of some of our political action committees that they'll pay for surgery of the joints but not conservative therapy, Maryland and Texas. Here's a patient, Cheryl Argent, age 29, previous orthotherapy, headaches, left temporal, occipital tinnitus. Widest incisal opening is 52, no restriction, anterior wall tenderness, high right eye. all the muscles involved, the right and left temporalis, masseter, internal, external, pterygoids, etc. Right and left TM joints painful, and the right collar. Okay, you take a look at that and you say, she's got a foghorn and saying, please, dear Dr. Dentist, won't you take a look at me? I'm overclosed a mile. And the dentist says, please, don't confuse me with the facts. You got all your teeth, there's no decay, come back in 6 months for a cleaning. This is where the patient is, that's where the patient should be. Look at this. I didn't make that. That's what she never got during growth and development. Well, somebody said, well, if you put in this splint, and she wears that for any length of time to depress all the posterior teeth. There was just a study done last year in the orthodontic department at the University of North Carolina, Profits Department, by Brown and Godet, that showed that that's not true. Scientifically documented. But look at the lingual inclination of these posterior teeth. Look at the bridges. The highest tooth is the central, the next highest tooth is the lateral, the next highest tooth is the cuspid, the next highest tooth is the first bar, the next highest tooth is the second bar. That's like standing up here on the platform and walking down into the basement. How come you don't see it? Look how much higher the plane of occlusion is here than there. And you're going to see that in mouth after mouth. So here, with just a little bit of a look, and taking a patient from a posterior superior position where the condyle may be right up against the external auditory meatus and bringing it downward and forward against the posterior slope of the eminence where it should be, some of these patients get better overnight. And they may have been suffering for 10 or 15 years. That's a disgrace, I think, at this time in our profession. There she is before. Look at the lips. Look at her after. Take a look at the lips. Now take a look at her. Which one would you rather kiss, this one or this one? And somebody says, neither, till I get her haircut. This fellow's a seaman. Look at his lips. He's got no vermilion border. So if you look at, just look at his face. I look at lips very carefully. He's showing you that he's got a loss of vertical dimension. This is him before, this is him after. Pseudo class 3. Look at that. Oh, he's got a lot of them. Boy, would you have a ball with this guy? I don't know whether he could afford to have him replaced, but you'd have a ball with him. He's a seaman. In this case, the mandible moves back, not forward. You're going to see these. And then there's no, this guy had severe headaches, and he got rid of it in that position. This is a fascinating case. Lovely girl, 18 years of age. Very constricted maxilla, crossbite here. The midline of the lower jaw is almost one central to the right. This is where she should be. So let me ask you a question. Which side do you think the jaw is off to? The right. That's the correction. Before, after. Before, after. And she had, this was created to a certain extent by a tongue habit. She had a posterior bilateral thrust. When she swallows, the tongue just went out both sides like that and created this discrepancy that you see here. How can you miss it? And 2 seconds later, in the right position, she looks like this. So what else does a dentist do that he doesn't get credit for, that every plastic surgeon should do or know? They perform a non-surgical facelift on most of these patients. Every patient over 40 will love you, especially the females. The difference is mammoth. Well, let's take a look at her x-rays. Look where the condyle is on the right. It's almost back into the external auditory meatus. You don't have to be a genius. I got a jaw that's off to the right. I put my fingers on her ear. She opens and closes. I feel the right condyle first. It hurts. I may even get a click on closing. Okay? Look at the opposite side. Look at the flattening and look at the lipping here. The osteoarthritic changes take place on the good side, on the compensatory side, on the overwork side. And the same thing happens to hips. So when she opens, the condyle should be right underneath the eminentia articularis. Right. Look at this one. Looks like the head of a bird. But now you start to put the pieces together and you start to understand what you're doing and what you're trying to accomplish. Okay? This is a case I was able to study very carefully. It's my son at age 7.5. He's a lot older now. He's got 2 kids. And he heads up the TMJ department at New York University. So I must have had some influence, I guess. Look at the lingual version of the deciduous teeth. The midline, he's overclosed, and the midline's off to the right. So we corrected the problem. And when he opened, the jaw tends to deviate to the affected side on opening. The jaw tends to deviate to the affected side on opening. That's where we should have been. So we were talking about sometimes you can use a posterior build-up and composite, which some people do on these deciduous cases. Put them in the right position so as the permanent teeth start to erupt, they'll come into where they should be. And at a little later age, you can start to do some orthodontics. He engaged in sports and everything else, and he felt better, so he didn't do anything. Now, he went to dental school. In his second or third year at dental school, tension and stress, got a TMJ problem again. It reoccurred. Exactly the same occlusion at 25 that he had at 7.5, but that's where the jaw should have been. Now you look at some other things. I start to look at the teeth. I look at the cuspid. I look at the first bars and second molar. Forget the curve of spade. These teeth are off the plane. Now I look at the cuspid here on the first bite. They're on the plane. The second bicuspid and the 2 molars are off the plane here by about 2 millimeters. Well, that permits the jaw to go further back on the fossa on that side without the support system that it needs. So you start, if you see enough of these and you start putting the pieces of the puzzle together, it starts to make sense. So, if I said to you, if you're an orthodontist, what is it worth for you, for me to give you the final jaw position first? In 3 months, I'll tell you where this jaw belongs. All you got to do, you can use any appliances you want after that. I'll get you the right jaw position within the first 3 months. You can use any appliances after that. I want you to finish to this position. You know how tough that's to treat orthodontically? You know how much easier this is to treat? So if you look at his x-rays, you see him go from a retruded mandible downward and forward and opening his ear. And you see the same thing on each side. They're bilaterally collapsed. They come downward and forward to the 4-7 position. When they go to the rest position and wide open, they're underneath the eminentia articularis. Interesting case. This fellow was referred to me by the wife of his boss. He worked in a restaurant in New Jersey. He was the maitre d'. Every day for an hour and a half, he'd have to go upstairs and lie down during the evening and take medication because his pain was so severe. He could not go to a movie and watch a movie for more than 20 minutes and a half hour without getting a headache. He couldn't watch TV for more than a half hour or so without getting a headache. He came to me, I think, around 1986. He had had headaches since 1962. He's got a class 3 occlusion, as you can see here. That's his occlusion. And that's the closest I could get him to where I wanted him to be to get him out of pain. I had him pain-free in 5 weeks. Now, in some of these cases, You may want to do orthodontia, follow it by orthodontic surgery, etc. He couldn't afford it. So in order to sustain him here on a temporary basis until he was able to do something, we made him an overlay appliance. There he is before, there he is after. And of course there's a missing molar there too, which complicates the problem greatly. So this is what we made him. We made him an appliance, an overlay appliance with metal stops to hold him in the right position. He had a periodontal condition here. This had to be treated as well. So all these other things have to be taken care of at the same time that you're doing all of this. Other factors that you have to consider in a differential diagnosis are the facial neuralgias, which I gave you before. Vascular headaches, we went through this, sinus disease, temporal arteritis, pulmonary involved teeth, coronary occlusion, fracture of the styloid, ossification of the styloid ligament, lesions of the tongue, injury of the auriculotemporal nerve, Frey's syndrome, otitis externa, and carcinoma of the nasopharynx. Okay, who hurts more? The heritage of pain perception. Each patient who enters the dental treatment situation has an individual set of socio-psychological factors which will affect his perceptions and the pain experience. Culture. I can't read it all, but people of the Mediterranean region have lower tolerance to pain than those of Anglo-Saxon descent. Northern Europeans and old, stock Americans have an accepting, matter of fact, attitude, etc., etc. People of Judaic background are more concerned with the pain than those. Okay. Race, in a recent study, tolerance to experimentally induced pain was highest among whites, moderate among blacks, and lowest among Orientals. While these variations may be related to innate differences in sensory acuity, it is more likely they are due to individual criteria for reporting pain. So culture and race play a role. Age should come down here. I can see it. I can't move too far with this. Numerous authors have reported increased tolerance to cutaneous pain with advancing age, while tolerance to deep pain is reported and increasingly diminished. However, when an equal amount of moderate pain was experienced by subjects of all ages, the younger subjects were more likely to call it painful. Thresholds of pain and tolerance in females has been reported to be less than are those of males. Comparisons of interactions of sex and age. Old females were found to have a decrease in sensitivity to pain. Childhood conditioning. Firstborn children may be less tolerant to pain than their siblings, but the degree of parental protection or the amount of independence in childhood could also establish attitudes towards pain that can carry into adult life. Previous dental experience or medical experience. Tolerance for pain is negatively correlated with the general anxiety experienced by many people in the dental setting. Furthermore, when the patient has had previous apprehension and discomfort, subsequent pain experiences can be more disturbing and his or her dental pain threshold may actually decrease. So these are the things we start to see that have to be considered when you treat these patients. Okay? There are perpetuating factors that include structural size and shape, discrepancies with any of the tissues of masticatory system. In addition, physiological disorders such as neurologic, vascular, nutritional, and metabolic disorders can predispose the patient to craniomandibular problems. Pathological factors include systemic disease and infections, neoplasias, and orthopedic imbalances, behavioral factors related to the personality profile of the patient and how the patient responds to stress, which can be expressed as noxious habits such as boxing and tooth clenching, which also affects the area in which you are also interested. Precipitating or triggering factors include trauma, not only to the masticatory system itself, but the entire head and neck of the patient, an adverse stress response, and iatrogenic problems, infection, and idiopathic factors. If a patient keeps their mouth open for a prolonged period of time, That can set them off. That can be a precipitating factor. An automobile accident, a fall, a blow, an injury. Biting down on a big sandwich, a submarine or a hoagie, that could do it. Perpetuating factors are manifested primarily by the myospasm pain spasm cycle and can be related to any one of a combination of the above predisposing or precipitating factors. Now I'm going to show you some interesting slides that I picked up in June in Kobe, Japan. There happens to be an organization in Japan very much like yours, surprisingly enough, called the Japanese Academy of Occlusion and Health. The thing that's amazing about this group is they realize there's a correlation between what they're doing and the rest of the body. And what surprised me even more is that most of the heads of the prosthetic departments at the various universities of Japan belong to this organization. And the guy who's behind it, who I think deserves a lot of credit, who was one of the initiating factors, is Takao Maruyama, who's head of the prosthetic department at Osaka University. An experiment was done, and I have the paper here, on the systemic effects of the peripheral disturbance of the trigeminal system. It talked about the influences of the occlusal destruction in dogs. They cut down the occlusion in only one quadrant. And this is what happened. And this is an explanation of what's happening. The dogs became lame, and the color of their furs changed. I think this is important because maybe it'll give you more of a neurological aspect of the problem and the pathways involved when changes are made here. Although there is an increasing amount of information pertaining to intracranial pathways of the trigeminal nerve, its clinical significance still remains unclear in many ways. Now, the author here is Tsuraki Sumioka, but there were some other people here who also contributed to this article, one of whom gave me the slides of the dogs while I was there in June. I assumed that dental disorders, including malocclusion, would lead to the disturbance of the central nervous system via the trigeminal nerve. Based on this belief, this study was conducted to find out systemic effects of the occlusal destruction by grinding teeth unilaterally in dogs. As a result, abnormal involuntary movement and symptoms of autonomic failure were observed. These experimental results indicate that the trigeminal nuclear complex contains not only the functions of the sensory relay in the face and the control of chewing movement, but it is likely that it modulates motor, especially postural control and autonomic system control. It is believed that the dental aspects, especially occlusion, play an important role for the proper functioning of the trigeminal system. Look what happened to the legs. This is what they did.
How long did that take?
Time, how long did it take? Let me just see. I think it was a matter of just months, 6 months. 6 months after the occlusal destruction.
Were they fully grown before?
No, the dogs, here are the teeth. This is what he gave me. Let me just, oh, well, this one, there it goes. They chopped the teeth down. They ground, I think you'll see it better in the next picture. See what they did? They completely ground down the teeth. They took a bar and they just ground the teeth completely down in one quadrant. And the dogs no longer had the stability that they had. Let me tell you a story. John Roberts was in my office this past week. A woman came in. She talked to us on the phone. We couldn't understand her. She talked, and she drooled. You couldn't hear her. 3 years ago, somebody pulled out the upper and lower left wisdom teeth that evidently were a stop. She missed every tooth from the cuspid back on this side. They put in 3 implants. They put a bridge here, and they put a bridge here. There was no real occlusal topography. She had nowhere to put her jaw. And the tongue was twice its size. So a dentist, she had seen an orthodontist who made her an upper appliance and just put some acrylic on it to hold it. So I worked her up, and at the first visit, I took that appliance and I converted it into a Farah appliance. That's a ramp. When I try to recapture a disc, I make one appliance that they wear during the day and another one for the night with a ramp so that they cannot go off when their head's on the pillow. I made that type of an appliance for her, but I widened it as well. It did not permit the tongue to come forward. Now, as she talked to me, I could understand her. Even with this in her mouth, she could talk to me like this, and I understood her. A week later, she came in, and I put the lower appliance in, and in several of the cases that I've seen lately, they have no occlusal topography. In other words, the occlusal of the teeth, upper and lower, is almost flat. There's nowhere that patient knows where to put the jaw, which probably is the same thing that happened to these dogs. So I give them a lock-in position. I gave her a position to which she could go to and find. Now, I was as surprised as you were. He was there. He saw the patient. In 30 seconds, she spoke to me perfectly, without a drool, without anything. She spoke perfectly, and she hadn't talked for 1 year. These are some of the things that we're seeing, which I think is amazing. Let's just have the lights, please. Can we have lights? Light, isn't it? My time's up, isn't it? Then we can stop here. Yeah, I think we better stop. I was going to call some people up and just show you in 2 seconds what I'm... No, they have to eat, don't they?
No.
You don't have to eat? Okay. Is there anybody here that has had pain, headaches, neck pain, or back pain for any prolonged period of time? Come on out. Come up here, it'll be easier. Maybe we can move that out of the way a minute. Okay. Tell them, how long have you had pain? Where have you had the pain? What happened to you? And what kind of therapy have you gone for in the past year or two or whatever it is?
I've had the pain for 13 months. Started in August of the previous summer. I've had pain in my left hip. And my husband is a chiropractor. So I've had many chiropractors work on me. I've had shiatsu, I've had you name it.
Okay. Have you had any accidents or anything? Did you have an accident, a fall, a blow, or an injury?
Well, I just had an enlightenment like 30 seconds ago. This is why I'm so excited now. I did have an accident. I was in a car accident in 1986, and I suffered whiplash injury. But a year and a half ago, I had 5 of my root canal teeth extracted. I have no occlusion on my left side, and it just occurred to me. And I have not had those teeth replaced yet. I put a transitional portion in my mouth, which I hated, took it out. I've got 3 of them in the drawer.
Do you have it with you here?
No.
Okay, now let's take a look. Close. Okay? Even though the teeth are out, the occlusion doesn't look bad. The teeth are out, but she looks class 1. Let's find out. We'll test her. Open widely, whole, we'll test her kinesiologically. Now close. It's off. Now you verify it this way, and you would also verify it with x-rays. I'm going to stay over here. I'm going to put my fingers in her ears, open and close. Close. Which side? All right, she's got a reciprocal click on the right side. Which one hurts when I do this? Does either one hurt? Neither.
Both hurt.
They both hurt. Which one hurts?
Left.
No. Okay, now I'm going to tell you where. All right. I've got an advantage. I've examined 20,000 patients. This is what normally hurts. I'm going to tell you where she's going to hurt before I examine her. Iliac crest on the left. Sternocleidomastoid and trapezius on the left. Suboccipital on the left. Splenius capitis on the left. Pectoralis major on the left. Deltoid on the right. Gastric medius on the right. Posterior cervical on the right. Does that hurt?
Yes.
Does that hurt? Does that hurt?
I volunteered for this?
Does this hurt?
No.
Okay. Does this hurt?
Yes.
Which one hurts?
Left.
Okay, normally it's right. This side of back will hurt, the other side will not.
Yes.
How about here? Not too bad. How about here, 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 here? Stand, don't move. Are you tender here? How about here? She's got every one but one. Now, if you put her in the right jaw position, give her back what was extracted, balance her out, then and only then can you get rid of the pain in that left leg and hip.
I'll see you Monday.
All right. Thank you. Do you understand what I'm saying? In its simplicity, it's radical. In its simplicity, it's radical. Who else had a headache or anything else? Come on up. And we'll do you, and then we'll be finished. Just tell them what your symptoms are, how long you've had it, whether you had any falls, blows, injuries, any work done, and what health professionals have you seen?
Chronic headaches up to if I can ever remember. This is right top of my head.
Splenius capitis.
Always, when I have that, I have severe symptoms. That's delivery on the right side. Seen better than a professional on there.
Okay? All right. Stand over here, please. All right, look at him. What is he telling you? Look at his lips. He's off on the right. The lips go up to the right. Most people's lips will go up to the off side. So, if you tested him, tell me which one do you feel first. Open wide. Close. He can't close with my finger in his ear. He can't close. Now, let me ask you a question. How many of you were taught to do this when you were in dental school? Zip. And you're doing bridges, and you're doing ortho, and you're doing implants, and you're doing composites, and you're doing superstructures. And you don't know where to put the jaw. Okay? Let's take a look at the dentition. Close. He's over-closed, and the whole dentition goes like this. Now watch. Okay? This one you can't even close on. Okay? He's going to be sore here, 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 here. Are you tender here too or not?
Not too much.
Are you tender here?
Yes.
Look, stay this way. Turn sideways. You want to measure forward head? Put this arm, put this hand in the middle of the shoulder, and put the other one here. And the difference is 3 to 4 inches forward of the plumb line of the body. Hurt? How about this? Does that hurt too? How about this? How about this, this? Nada. The right almost never hurts. It's always left. Good side. Compensatory side. Overwork side. Happened the day he was born. Are you tender here? Here. Are you tender here? Are you tender here? Are you tender? Well, those I did. Okay, I did that, I did this, I did that. So that's pretty much it. Now watch. You now verify the jaw position with his brain. It's his body. He knows where the jaw should be. I have a good idea, but he's got to verify it. If the body doesn't verify it, I can't put it there. And we've documented this scientifically at Tufts. Open wide, hold, resist. Okay? Now I'm talking to his brain. Hey, brain, how do you like this position for this gorgeous creature? Close. Hold your arm up. Come on, hold your arm up. What the hell's wrong with you? The moment you're at the proper centric and vertical, you can chin on his arm immediately. If he were a weightlifter and I sent him to the gym, he would immediately press 25 to 30 pounds more. Immediately. I have an article coming out of the New York State Dental Journal in November on just this. Muscle strength and muscular performance in sports dentistry. I went through the whole literature for the last 20, 25 years, and it's all in there and it's all documented. Thank you very much. Yes.
You were talking about confirming combo position with 4-7 radiographic.
But they're not going to end up in 4-7. That's ideal. When they're well, they may not. Most people are not in 4-7. You don't have to end up in 4-7 when you're well, and most of the cases will finish off the disc. But healing will have taken place by having kept the jaw there for 4 months. Oh no, that's only, I'm only giving you that criteria so that you have a better understanding of what I'm doing when I move the jaw to a specific position for healing, during the healing phase. Because when I'm done, I couldn't care less as long as they're well. Okay, thanks again.
We will be having a forum, by the way, at the end of the afternoon. Dr. Gelb will be that for the rest of the day. We're going to break for lunch now. We'll be back here at 1:30. Take an hour or so for lunch, and then spend at least about 15-20 minutes with the exhibitors. See you back here at 1:30.